You made a very important statement, is the earlier the start, the safer it is.
Like women had even no idea that they were experiencing perimenopause because, again, nobody talked about it.
Yeah.
It used to be this taboo topic. I mean, clinicians didn't know about it. So in the meantime, we spent months, sometimes years, not sleeping, having a mood change, brain fog, fatigue, all of those things. And you were told, well, nothing hormonal is going on because you're still getting periods. And that's not really true.
Right.
Hello, and welcome back to The Vitals, Mount Sinai Health System's groundbreaking new podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. Today, we have a special edition of the show. We're going to commemorate the opening of Mount Sinai's new Carolyn Rowan Center for Women's Health and Wellness. To discuss the opening of the center and the center's new women's health-centric podcast, HERology, we're joined by the Rowan Center's most prominent doctors. We have Dr. Joanne Stone, Dr. Anna Barbieri, and Dr. Leslee Shaw. Thank you so much for being here. Okay, so to kick us off, what is the need for a dedicated women's health center? Where did this come from?
Well, I think that women's health has been completely under sort of resourced and has been sort of not so important. So there was a real need for having a center that really highlights women's health and how we can prevent diseases and how we can really treat people differently. We're not, obviously men, and, the biology is so different. So
Right.
It was so important to have a place where we can just totally focus on women's health.
Yeah. One of the things that we had spoken about is you said that the need is coming from a place also where you wanted to dedicate care to specific phases of women's lives. And so how do you guys do that in the center?
For sure. And that is one of the things that differentiates women's health from men's health also. There's specific transitions and phases in a woman's life, like puberty, pregnancy, postpartum, perimenopause, menopause, and that these are the transitions that influence her entire health span, potentially lifespan. So we wanted to highlight that and bring it together.
Yeah, women go through like pre-puberty, puberty, like all the hormones that come with like getting your period, having babies. So that's like a lot of hormonal changes where I guess in theory men kind of go up, stay up for a while, and then come down.
Yeah, and the transitions are pretty unique to women. So we just wanted to bring it all together under one roof, so to speak, and highlight that.
Okay. One of the things I wanted to bring up today was, the whole point of this show, and I know this is a crossover show, but it's a perfect crossover for you guys, is one of the hot topics out there, especially if you're on like Instagram or TikTok or something, is we're talking about hormones, peptides, basically anything that you can put on or in your body to improve things. So let's kind of talk. I want to start off by talking about hormones because that's what everybody wants to hear, and we need to hear it from the experts. So the hot topic out there right now is peptides. And some of the most popular peptide are these GLPs, which actually affect your hormones. So what's the big hoopla about specifically I'm not talking about like just diabetes related. I'm talking about like optimization related.
Big topic. I think maybe what I will do, let's take a step back and talk about what hormones are and what peptides are. Because I think a lot of people, and especially on Instagram, there's quite a bit of confusion over that. So peptides can be hormones and hormones can be peptides, but they're slightly different terms. So basically a peptide describes the structure of something. A peptide is like a string of amino acids, and amino acids, for the audience's sake, are building blocks of proteins. And then hormones are substances that are made by a certain organ in the body, travel through our blood, and have distinct actions on multiple or distant organs, for example. So we have peptide hormones. And we ask about GLP-1s. Perfect example. That's just one example of a peptide hormones, but there's plenty of other ones. And then we have sex hormones, which are sex steroids. And these are the hormones a lot of people talk about when it comes to the hormonal transitions in women's lives. So whether that is puberty, whether that is getting pregnant, whether that is postpartum, and certainly when it comes to perimenopause and menopause, and those transitions for the largest part are influenced by changes in sex hormones, so estrogen, progesterone, testosterone. And then GLP-1s, a subset of peptide hormones, are also influencing those transitions. We understand that to a point. We all have natural GLP-1 hormones in our bodies. The medications that are on the market now that everybody wants to know about, so GLP-1 receptor agonists, GIP agonists, and there's another third one that's going to come out probably this year or next year. I'm going to stop talking very soon, which is going to be a triple agonist.
This is what people want to hear.
You know,
They need to hear it from people like you, not the influencers with no medical degrees.
So these
And
are...
then I heard in Europe, though, this is just recently, just to throw this in, then you can answer,
Yeah.
is there's a combo now, GLP-1 plus estrogen drug that is being
now
developed.
we're talking.
So just as a segue,
I mean,
as a segue for
is,
you.
It's a really, really exciting area that's developing, and we're just starting to understand the interplay of these agents.
So let's go in order for our listeners. Anytime you put something on or in your body, hopefully this is something that can be prescribed by a medical professional, not something you get off like a black market website. So there's FDA approved hormones, peptides, medications. Then there's things that you can get from compounding pharmacies. And then there's things that you can get from the black market. For our listeners who can get things from doctors and all of these places, how do you know if you can get something from a website or compounding, that sounds safe to them? So how do you know the difference between what's safe and what's not and what they should be doing? Let's just focus on the hormones, I guess, and then we can get into the peptides.
Well, I mean, the FDA does a rigorous process, and I think that aligning yourself with FDA-approved drugs and FDA-approved marketing and development of those drugs so that you understand the indications for those drugs and align yourselves. Going to a compounding pharmacy is just that. They make it there. It could be large scale. It could not be necessarily made in the United States. And there's some issues with the safety of those drugs. And I guess, not only would recommend staying to a pharmacy and things that are prescribed by my two folks on either side of me, but, to stay within the FDA-approved drugs.
Right.
That's not to say there aren't websites that you can get GLP-1s on that you would converse with the physician on. I would also put those in kind of a good...
Yeah, they're FDA approved.
Right, 100%.
Right.
100%.
But some of there's a wide variety of compounding pharmacies, and some are really good and make really good products, and other ones are really not as reliable. So I think you have to know, and from the physician standpoint, some physicians prescribe medications from compounding pharmacies. So you really have to know which pharmacies are trustworthy.
Right.
Yeah.
So estrogen, progesterone, testosterone, these are all things FDA approved you can get from any pharmacy. And then there's Samorlin, where you have to get from a compounding pharmacy. That's do you guys even use that for your patients? Do people ask for that?
So it's not used very frequently, although there are some prescribers that are starting to use it. So the way I think about kind of the FDA approved versus compounded versus gray or black market, sort of think about those all these compounds in three categories. First, there's FDA-approved drugs that you would get from, let's say, CVS. So we write a prescription. That compound, that medication, that agent has gone through this rigorous FDA approval process. There is typically a randomized clinical trial that documented efficacy, safety, side effects, and so on.
At least one, if not more.
Correct.
Right.
Then there are compounded drugs that you can get from compounding pharmacy that will have an ingredient that's FDA approved, although the creation of that particular compound is not under FDA regulation.
Right.
So Sermorelin, for example, this used to be an FDA approved drug, I think in the 90s, and the indication was growth hormone deficiency in children.
Right.
That drug is no longer produced, so it's not an FDA approved drug, but the ingredient has gone through the FDA approval process. Right. And that's still different from these gray market, black market.
Where people are using it to build muscle and cut up.
It's a lot of peptides in kind of the health span and longevity space that belong on that. Some of them have very, very limited to no human data and really are advertised for, energy and vitality and may have just some mice studies behind them. And some will have some human data, but again, very limited. So I share this story sometimes. I had someone email me about a website that they were going to use to purchase these items on. And the question was, what did I think? Well, there are definitely some red flags you can look out for. If the website takes crypto, if there is no address, if it's just a random email, if it says you can't contact the manufacturer and you're out on your own,
Right.
those are some really worrisome red flags. I would definitely not recommend
No
that.
information where the production facility could
Totally,
be in China,
totally.
could be anywhere.
So when we can, I think it's obviously safer, cleaner, better to use FDA-approved drugs. There are compounded agents that we also use, especially in the event of cost, shortage, supply chain issues, things like that. But again, I think it's really important to know your way around compounding pharmacies.
So how has your practice changed in the last year or two with like the removal of the black box warning from hormone replacement therapy, which is, I guess, no longer the acceptable phrase? What is it supposed to be now?
It's supposed to be hormone therapy or menopause hormone therapy, but HRT is still used all over, so it's the same thing.
So are your patients asking you guys for replacement now and trying to optimize?
I'll let these guys talk. I mean, I'm chairing a national guideline right now, and it's on primary prevention and, like lipid abnormalities, et cetera. And it's caused a lot of consternation because physicians are not that well educated. They've gone through how long was the black box? 25 years or something like
I think more than that.
2002.
something like
Don't
that.
know,
So,
yeah.
so that's just like erased it from people's minds. As clinicians, they're like, what do I do? What do you mean? People are coming in and
Yeah,
asking
that
me.
we can hide
I
behind
know.
it for a long time.
Yeah.
I don't know, and
It's easier to not talk about it. Yes.
exactly. Just I don't want to know, right? And so I'll do that as a segue to you guys, but I think there is a strong need not only for people, patients listening to this, but for clinicians to spend the time and figure out the key factor. And one more thing that I'll say is whatever we use when the black box warning went on to this drugs were higher dose oral, much different than what we use today.
Right.
That's a critical factor in terms of safety. The older drugs had some safety side effect profiles, which you had to be very careful about. Today's marketplace and utilization is decided more transdermal preparations, lower dose, et cetera. And I'll let you folks comment on the rest of it. That is just, where we are. People are just looking, deer in the headlights, if you will. What do we do next?
I mean, I think you make a really good point, and I think a lot of physicians are just not educated when it comes to sort of the hormonal treatment. It's lagging in our medical students and our residency. People don't learn much about menopause or perimenopause. We have internists that take care of women and not sure how to prescribe medication. So we need to do a much better job of educating the physicians, whether they're internal medicine, whether they're OBGYNs. We need to do so much better.
What are some of the do's and don'ts for prescribing?
Well, I think knowing how to prescribe is a start. And to this day, I think medical students often will get just 1 hour of education on menopause in general, let alone hormone therapy.
That's so
prescriptions,
sad.
which
It's
is
gonna change. It's just so sad.
It's just wild, I think certainly knowing risks and benefits. I think when the FDA warning came on, the label for hormone prescriptions many years ago, 2002, was sort of a knee-jerk reaction which was supposed to be the right reaction to these older, higher dose oral regimens that may not have applied to all the regimens out there. I do think the pendulum is swinging way in the opposite direction. We do see patients all the time coming in, no matter the age, no matter the medical history, no matter the need, people want hormones. So now there's this push towards hormones for everybody. And I think that decision requires nuance.
Yeah, so like somewhere in the middle.
Every intervention has risks,
Right.
benefits, potential side effects, and needs to be a really thoughtful process.
Right. So like some of the things that you see out there, because, I like doom scroll a little bit on Instagram, is like I'm perimenopausal, right? So, and I started my estrogen replacement therapy probably like 2 years ago. I noticed a big change for me. That's for another episode. But what I learned from my doctor was you don't wait until you're miserable. You started ahead of time to hopefully avoid the misery. So we did the right thing. We started the estrogen. We titrated up. I was allergic to the patches. I switched to the gel. I take my progesterone at night. So like, what are some of those little tips and tricks? And when should women Forget about like trying to do it ahead of time. When is like the right time to ask for it?
So yeah, I think this is so critical. So in the Carolyn Rowan Center for Women's Health and Wellness, the pathways that have been created, and Anna and her team have created different pathways, and one is a pathway specifically for 4 to 6-year-olds. So you go through a guided pathway, meet with a physician first, PAs, and you go through a whole process so you can figure out what are the exact needs. And it's a time to listen to somebody's symptoms.
And it's not just like blood work, it's actually how you feel.
It's how you feel, right? So you may need, if you're having problems sleeping, you may be directed towards a sleep specialist. If you're having problems with, hot flashes, it's another form of treatment. So I think really listening to the patient and going through this whole guided clinical pathway is just such a differentiator in terms of what we're going to be providing at the center.
I think, the important thing really for any woman to know is how to recognize that her hormones are changing. And that's been a major problem in the past. Like women had even no idea that they were experiencing perimenopause because, again, nobody talked about it. It used to be this taboo topic. I mean, clinicians didn't know about it. So in the meantime, we spent months, sometimes years, not sleeping, having a mood change, brain fog, fatigue, all of those things. And you were told, well, nothing hormonal is going on because you're still getting periods. And that's not really true, right? You can go through this entire, process and be in it for literally years without a major, major difference in your cycles. There's usually some subtle differences. And that's why, we've been talking a lot about how to design better care for women in this space. And for us, it also means kind of being preemptive and proactive. So really by the age of 40, we believe every woman should be aware of what that change looks like, because at least then you know what to anticipate and how to kind of figure out what's happening so you can get help.
What's your top list of, what would you say like the biggest complaints are with women that you're like, oh yeah, it's starting?
Gaining weight.
Yeah, gaining weight. So, but we need to step back because both of you said, I think just needs to be underscored a little bit.
Okay.
Your estrogen levels are going to start to decline in your late 30s. Let's just put that out there. So you are not even remotely thinking about menopause at age 35, right? Not even remotely.
Right.
But you're going to start to get that decline. You need to start to have those conversations. You made a very important statement, is the earlier the start, the safer it is. If you wait until you're in your mid to late 60s and you want to have this just because you think of this, there do become some risk and safety issues in older age women.
Oh,
so
like what?
Well, it can have some clotting effects.
Right.
So clotting to the brain, strokes, clotting in your heart. You can have a heart attack. In people who are in the trial data, it was like 67, 70 years old and older.
Okay.
So there are some issues, but the big thing is to focus in on prevention early on within that menopausal transition, when you and have those discussions well before you start to feel vasomotor symptoms or sleep issues or frequent UTIs or whatever the indication is. And these are really important.
I think, for so long we thought of menopause symptoms as hot flashes, night sweats, vaginal dryness. Yeah. Those are symptoms that are due to low and prolonged low estrogen levels. That's typically not the first symptoms of perimenopause. Usually when you look at those first initial few years, it's going to be a slight shift in periods towards shorter cycles. It's going to be worsening of PMS. It's going to be breast tenderness. It's going to be water retention. It's going to be a mood change and insomnia. That's kind of the classic set for early perimenopause.
And you start to hate your partner.
What's that? I was going to say mood change is so kind. I want to multiply that by 100.
Impatience,
No, but it's such an important point. And I did have somebody that said to me that I think we were giving one of our talks and whatever, and they said, if I'm feeling fine, I'm 42 and I don't feel any symptoms, why would I need to go there? And because some of it is because, number one, you don't even recognize the symptoms that you are having. Number two, you want to get on that pathway of prevention and preventing all those things that you just were mentioning.
Yeah.
Yeah.
I mean, that's not to say, we don't need to treat every 35-year-old with hormone therapy. So I want to be careful
Well, you
saying
said your
that
pathway,
too.
like at 40, they should enter your pathway at your center.
People should know how to interpret the signals of their bodies by 40, if not earlier, Leslie.
Yeah,
I agree with you.
100%.
Yeah.
Earlier. Right? That doesn't mean that every 40-year-old should be on hormone therapy. We also don't want to medicalize healthy people that may not have started the process yet. Like, this is super individual. We see patients who are entering that process at 35, maybe earlier, with people who really feel fine and don't notice much of anything and don't have a significant hormone.
But why
change
can't the
until their
process
40s.
just be, it's really important to get 8 hours of sleep at night. It's important to eat protein
100%.
and high carbs. It's important to weight lift. Maybe you should wear a weighted vest. We'll talk about that. But like sometimes the process is just like, these are important things also.
That lifestyle piece comes in always.
Yeah.
But they are more poignant is when you start to see increases in visceral adiposity, i.e. your waist circumference gets larger. And, you go from a population that has, a 20, 30% obesity to 60%.
Right.
You have an increase in insulin resistance. Your cholesterol goes up. Your good cholesterol, your HDL cholesterol goes down. Insulin resistant. All of these factors increase very dramatically in the prevalence. So
And that starts in early perimenopause
Yeah.
too.
And so
So the pathway needs to start at 30, ladies.
you need to be early. You need to be early to avert some of these because these medications, menopausal hormone therapy or hormone therapy, will actually ameliorate, actually reduce visceral adiposity. They'll improve insulin resistance. They'll maintain your cholesterol. They'll have very positive cardiometabolic effects, which are so important to when you're talking about lifestyle changes.
Right.
When you talk about lifestyle changes, they're most poignant to the woman who's gained weight. Not that I'm pointing and I'm looking at myself in the mirror, but I think that. And so if you can avert those, isn't that the best way to do it?
It is. Yeah.
So
Well,
sorry,
I
I
think,
interrupted you.
I think we're at a point in time when there is this massive sea change in how we think about hormone therapy. Up to recently, hormone therapy used to be viewed, and this is what it's still actually FDA approved for, as a short-term intervention for specific symptoms, like a course of antibiotics. Let's say you've got a UTI, use the antibiotics. You've got hot flashes, okay, use hormones for 6 months, no longer than 2 years. Now we're starting to finally look at hormones as something very different, similar to what I would say, Leslie comes from the cardiology world, blood pressure management, right, for prevention of stroke. Hormone therapy really changes physiology, metabolism, long-term outcomes. So it's really, we're moving away from looking at this as this temporary fix for symptoms towards improving your long-term physiology.
Yeah, I think there's like
Well said.
that was helpful for me, even like the misinformation out there or like just a little bit of information is ask your provider about hormones. It'll make you feel better. You won't yell at your partner so much. But like now you're like, there's estrogen receptors everywhere. They're gonna
Unless
help
that
everything.
partner deserves it. I mean, it's not, hormones are not
Stick up for
always the
yourself.
excuse. Yeah.
Hormones are not always the excuse. So let's say there's a patient out there who has like a very strong history of like family history of breast cancer. They're not really like, they know they're not an HRT candidate. Like, is your center still appropriate for them? Are there still things you can do for them?
So one of the big things about the center is that we're some of our leads like Dr. Barbieri, Calipari have gone through an integrative medicine fellowship. So there's other alternatives that we can use that we can bring to the table.
Are they peptides?
Not peptides. So there are so many other options and things that people don't even realize are available and that are effective. So when we go that route too, we're not just straight, Eastern, Western medicine.
Right.
We're doing both, right? So that's really important to bring to the table.
And Leslie, like that example is such a perfect example, right? Somebody with a really strong family history of breast cancer. That's actually not a definite contraindication to hormone therapy. That's a good reason to have a really well-informed discussion with that patient. Having had breast cancer, having had, hormone positive cancer, it's a different story.
Right.
But family history like really changes that. So, our goal is to really have women be informed of all the options they have and make the right decision for themselves.
And what about, like, that's great. We're talking about all the women that like are in their, we added 30s, but like 40s. But what about like puberty, teenage, 20s? Like how are we helping these women? Because you guys said that it has to start early. It has to be preventative. So how are we doing that for the younger generation?
I think, providing care, we're providing care at all different ages. I mean, we have also postpartum pathways for patients who had deliveries and pathway for that. But I think bring them in and educating them. So that one of the things that we're doing in the center, besides podcasts to help educate, but we're going to hold educational events and bring them in early. I mean, it's also a place that you can see your regular GYN and get sort of that care. I mean, a lot of people don't know that, they're going to start losing bone at age 30 and they have to start exercising, really. That's part of their lifestyle, that weight-bearing exercising. So we want to get to them early. So educational programs, webinars, things like that we'll be doing to provide care for that.
That's such a good point. So the center is supposed to be about longitudinal care of women. So let's take bone mass. So something like 80 to 90% of our bone mass becomes accumulated by age 20. Okay, so if you think of osteoporosis is really not a disease of older age. Osteoporosis, you're set up for that when you're a teenager. Like we should really look at sort of these long arcs of health and start introducing even lifestyle interventions.
Should like all 20-year-olds be wearing weighted vests wherever they go?
You should exercise, eat enough protein, move, for sure.
It's interesting because all of us in the room were trained under largely a model of caring for disease. And there's this massive shift going into earlier and earlier prevention. So we avert the diagnosis. A lot of this that we're talking about, whether it be diabetes, whether it be obesity, we can change that pathway that we're seeing today. There was a paper out last week that said that 60% of women are going to be obese by 2050. 60%. So that means in a healthcare setting, it'll be like 80%.
Like globally or just in the United States?
United States. 25% will be diabetic. Over 60% will be hypertensive, high blood pressure. That trajectory has got to change. And the only way we do it is we take a
How did that happen?
8-year-old and 10-year-old.
How did that happen?
Well,
Sorry, I just opened up Pandora's box. Why?
The podcast, we don't have enough time. I mean, just look around you, how it's changed in your own eyes. And the sad thing is that we used to see it just in the United States. Now, those of, we travel, you go to the UK or you go to China, you see obesity that you've never, ever seen before.
Our food is changing. We're staring at our phones.
We don't exercise.
We're not moving. We're stressed.
Eating all the wrong foods.
All the time.
And it's just this massive cycle. The big thing about going to a center like this is that these guys, and as a researcher, we're changing the paradigm. We're putting, the strength in your hands, knowledge in your hands as a patient to become empowered to change your life, even if it's a few more steps than you took the day before, even if it's eating a banana or, small changes, but really, really breaking that cycle. If we don't, we're going to break the system in terms of caring for 80% of the population that's obese or diabetic or that. We're just not going to have resources to care for people. And we're going to start to see massive changes in life expectancy, which would be tragic.
And I'm really, listen, I'm a maternal fetal medicine specialist. So, I see these patients who are obese, diabetic, hypertensive, having babies, right?
Right.
So the risk to the mother is much higher. So we and also risk to the baby. There's more preterm delivery. There's more babies that are either too small or too big, and that has other health implications.
And those effects are lifelong.
Lifelong.
Yeah.
So really, it affects really so many different aspects of life.
It's amazing.
I think, we do want to empower people to live the best way that we all can, to know that we have agency over our health. But that goes to a point, and that's why we have the tools of modern medicine, whether that is hormone therapy or GLP-1s or whatever you have, because there are some things that it is not enough to take enough steps during the day to help with something or prevent a condition. And that's why a center like this that really combines prevention with empowerment, education, agency, and the right tools chosen in the right way for the patient in front of us, that's where the real power and so can change people's lives.
So then how are people supposed to use you? So like I have a primary care doctor, right? And if there's something not quite right, she'll say, go to an endocrinologist or a cardiologist or whatever. I see my gynecologist once a year. My kids are 17 and 19, so I don't need an OB. Do you want people coming to you as an adjunct to their internal medicine doctor in primary care? Or is this like, come to you guys, you'll coordinate everything that is needed for the woman?
So I think there's a variety of things, right? So you can come in and maybe you have uterine prolapse, where the uterus is sort of too low, and you need to see a specialist for that, right? So you can come in and just see that person and get that condition taken care of. Or you can have your gynecologist and say you're 42, you're starting to have symptoms. Say, you know what, this is a really great limited pathway. It's 6 months. Go through this pathway, and then you'll come back to me at the end of it with a regime of medications and lifestyle changes that you've already accomplished, and you're going to continue that way. So there's different ways of doing it. I mean, in the postpartum pathway, that's for somebody that's 12 weeks postpartum, right? And we know that, women who have had either vaginal delivery or even a cesarean section have certain needs. So pelvic floor therapy,
Right.
or treating the rectus muscles that may have separated or something like that, have these needs. So you can have your own obstetrician come to the postpartum pathway and then go back to see
So you guys are like
Joanne.
supercharged quarterbacks for a while.
Yeah, exactly.
Yeah.
Okay.
So the difference is, let's say you're 45 and you're not sleeping and maybe your mood is changing. You're like, oh, I'm too stressed. I'm working too much. My partner is bothering me, whatever it may be, but I'll bring it up to my doctor. And
Right.
most of the time, like your primary care doctor is not going to have had much menopause-related education, may not know their way around hormone therapy. Maybe you'll end up with a prescription for an antidepressant. And maybe that helps, maybe that doesn't, but that's it. And maybe you have palpitations because that is also a sign of hormonal fluctuation and you get sent to a cardiologist. So we're trying to really change that around. So you come to the center and you go through the midlife pathway. You first start with a big, deep, personalized evaluation. What are your
And who does that
symptoms? What is
evaluation?
your history? So our clinicians do that. Biometrics, body composition, your lab values, not looking at your hormones only, because hormones also change a lot in this whole perimenopausal period, looking at your cardiometabolic risk factors, looking at your micronutrients, putting all of that together, and then we design a program for you. So our midlife pathway, it's a 6-month of kind of design, curated care experience where you go through nutritional counseling, movement counseling. You may get a prescription for hormone therapy according to your need. We cover things like sexual health, metabolic health, address whether somebody needs lipid management or blood pressure management or weight management, whether that is, with nutrition and movement or whether that is medical weight loss and medical weight management. So really paying attention to all of these different tenets of health so that one can leave after 6 months having had a really effective, deep experience and move on with the rest of their life.
Can I just say one more thing? Is just to ask you guys something, because I know you work a lot about work efficiencies or the work up efficiencies and navigation. Maybe you should, because I think that's an important sell. You're not going to see a doctor every 6 months. I mean, if you go to your cardiologist or this and that evaluation becomes 5 years long or whatever.
Right. No one talks to each other.
Yes.
Yeah.
So I don't know if you want to talk about, because I think that's really a point.
It's a really great point. So one of the great things in the center is that we have other specialties that people will talk to each other. So we have endocrinology in there, we have cardiology, we have orthopedics in there. We're going to have brain health in there. We have liver disease, GI. So these people will be patient navigators, so they'll be making the appointments. They'll see the specialists within the center, and they'll talk to each other.
Will you guys do telehealth also?
Yeah,
Yeah.
telehealth too. And,
Really
and
helpful.
some of these pathways are also telehealth. So it's really, it's so hard as a patient to navigate, going to the cardiologist and then going to the endocrinologist.
Yeah, and did so-and-so talk to so-and-so? Yeah.
Right, and then you put it on the patient, say, well, what did they tell you?
exactly.
In this way, they're all talking to each other. We're in the same place. We're working together to take care of the whole person.
Right.
And the other thing I just wanted to mention, we've talked a lot. We've talked about young people. We've talked about perimenopause, menopause. We also are not forgetting about the women who are above the age of 60. You know, people are living longer now, so we want them to live longer and healthier, active lifestyles. So we also have a pathway that's for 60 plus that really is looking at their health, how we can optimize their health as well. So it's such an important age group, I think, that maybe is not, you know, so in front of, you know, on Instagram and TikTok and things like that. But it's such an important age group that we're paid attention to and make their lives as, you know, wonderful and healthy as possible. So
that's a good age group for like a lot of the educational stuff that you're doing, because that's like the lonely age group.
Yeah.
Like getting them out and doing maybe group things. Yeah.
Yeah.
I know our time is coming to an end. I wanted to do rapid fire with you guys real quick. So I'm going to say something and like pizza. And you're I'm not going to say pizza. And you're a 0 out of 10, terrible, don't like it. 10 out of 10, love it, need it. You guys can all answer. All right, we're going to start. Increase protein in diet.
Love it and need it. You know, definitely.
What number are we giving it?
9.
9.
Because you can always overdo things. So I'll give it a 9.
I just don't think we can meet the new dietary guidelines. I mean, it's like, on average 60% higher than you're currently eating.
Yeah.
I mean, that's the
You have to eat cans of sardine and tuna every day.
Yeah, and then you
drain the oil out.
Mercury poison.
Yeah. And then rotate with egg whites and rotate with chicken breast. Yeah.
Yes.
Increasing carbs in your diet instead of decreasing them like many women.
If you have a very, very, very active lifestyle, you're going to find the need for that. You know, but that is the rare
Already say.
patient.
I'm going to give it a 5
Yeah.
because it all
I think a
depends.
5. It all
Yeah.
depends. I agree.
Okay.
Yeah.
Weighted vest.
Hard on your joints. I'm
Hard on
just
your
saying.
joints. Okay, weighted vest if you're not obese.
As long as it's not too heavy, I'll give it.
Uh-huh.
I think they said like
7.
you're supposed to do like 10% of your body weight.
Yeah. 7.
7.
I mean, I think the first thing is like, we got to get out there and move.
Yeah,
Like,
Okay,
humans
next,
are made
well,
to
next
move.
is heavy lifting or just lifting.
Yeah.
Okay.
I think weight bearing is really
Yeah.
important. So
Weight
important
bearing.
for bones.
And
yeah.
like supposedly jumping, you're supposed to like tell your joints and your bones that they're needed. Okay. Testosterone.
Oh, that's an interesting one.
7.
7.
Yeah.
I mean, very useful for some women. Has some side effects.
Okay.
Doesn't work for others.
Sex.
Do we like it? Do we want?
We're talking about
Is it? Can you do it? Or
We need-
what is that?
is it important for your health, happiness, and emotional well-being?
We think so, and this is
Yeah.
why we have somebody that specializes.
It should be brought up. That's a 10 out of 10.
Yeah.
Yeah.
Okay. Should be
Also
brought up.
individual, but should be brought up. Yes.
Getting 8 hours of sleep or getting enough sleep, 7, 8 hours.
100.
12
100,
at least.
12.
All right.
All right. So that's a big winner so
Yeah.
far. What about alone time or relaxation time, like de-stress time?
15.
Yeah, I agree. 100%.
Well, it's so hard to do, but you know, it's so important. But you know, it's not.
is hard to
Yeah,
do.
it's really hard to do. I mean,
Yeah.
try to meditate, and when your mind is
You know,
working
there's
20,
Yeah, we're like,
No, we're ending.
obsessive multitaskers.
exactly.
yeah.
What about
We should do a whole
supplements?
podcast on that because I think that's
Yeah.
usually
What kind of
important.
supplements?
Yeah.
I'm going to be broad for time, but like it's the same concept of like I want to go on hormones, I want to go on peptides, supplements. It's like, you know, taking like I'm not talking about like the vitamin D deficient person, just like taking extra supplements.
It's like creatine, magnesium.
Yeah,
those
let's go with
have been
those.
pretty good. So
Yeah.
you know, it's not essential, but those have some good data behind them.
I'm going to go with 5.
I would
Yeah.
say 5
Some
or
great
6.
ones
Yeah.
and some really stuff that really doesn't do anything.
All right, last one, topical retinol.
8.
I think, yeah, I would give it a plus.
We like it. Well, I want to thank you guys so much for being on the show. Is there anything that we wanted to talk about? I didn't ask you that you guys want to just throw in at the end.
Well, we're just so excited really about this, and thank you for
Yeah.
for hosting us. And it's so important that this has become such priority for the Mount Sinai health system, and we're
Yeah.
just thrilled to be able to provide really outstanding healthcare to women.
And
So-
change healthcare for women.
Mhm.
Like,
Right.
I think it's about time.
And get people just to check out the center. It'd be
Yeah.
awesome.
We need to get a line out the door because what you guys are doing, like, we need to change the way that women are treated. I don't want us to be an afterthought anymore. We need to be the priority. Like, we are the priority. So let's be the
are.
priority.
Exactly.
Yeah.
All right.
Be
Thank
part
you.
of the revolution.
Thank you.
Yeah.
Thank you.
Thanks.
That's it for the show. I'm your host, Leslie Schlachter. Subscribe to the Vitals and Mount Sinai Health System's new Roundtable Women's Health show, HERology, on YouTube. For audio-only versions, check us out on Apple Podcasts, Spotify, or wherever you get your podcasts. For more information on the Carolyn Rowan Center for Women's Health and Wellness, or to book an appointment to see one of our specialists, scan the QR code on your screen or click the link in the description below.